Hello guys, hope I'm audible and visible. Hello guys, hope I'm audible and visible. Hello Suresh, hi Rahul, good evening. If you can hear me and see me, say a hi, hello. Hello Priya. Hope you can hear me and see me. Fine. So let's start one more session of the Read Robbins with Dr. Ranjith. So we are in the chapter of intercellular accumulation, right? We had seen about the fatty change. We saw yesterday about protein and hyaline accumulation and also glycogen accumulation. Good evening, Lan. And now, good evening, Nayak. So now we are going to see about the pigments, right? So tomorrow is about calcification. That will end the intracellular accumulation in toto. Fine. So we're going to see about pigments. What and how will a pigment or a color give us clue to diagnosis? Like I said in the start of the lectures, my main goal and your main goal for now and in the future is only one: to diagnose patients and to treat patients. Right. Our main focus is how it's going to help me in diagnose. Right. Now I'm going to ask you a very random question, which I want everyone online here to answer. You might be right, you might be wrong. Please don't worry about it at all. Right? Tell me whatever comes to your mind when you think of a pigment accumulation. Need not be from Robbins, from your original knowledge, what you had from physiology or from your 12th standard, which can be colorful, black, brown, any color, which is there in the body. I'm sure you know quite a few of them already. I just wanted to answer that. Whatever comes to your mind. You might be right, you might be wrong. Like I said, doesn't matter. Great. Priya and Nikki started with melanin. Do you know any other thing which have pigments? Tattoo can have pigments. Melanin is a common vote. Anything else apart from melanin and tattoo? Okay, you must have definitely heard about this. It's a breakdown product of heme. What is that and what color will it have? Perfect. Harsha's told bile, right? Correct. Bile. Bile is also a pigment, right? So can I say, since Harsha's started with bile, can I say it's only yellow in color or is there a possibility I can have a green color pigment also? Nikki has answered hemosiderin. Is there a possibility I can have green color pigment? Biliverdin, right? Bilirubin, biliverdin, lots of them, right? Right? So before giving rise to giving an answer to any question, be it a viva or be it a university exam or be it NEET PG next anything, just think for a couple of minutes. That's enough. Just 1 or 2 minutes. That will give you a structure of what I can answer. Because if you look at Robbins pigment section, it will be very small. But if you think for 2 minutes, you know more than what is there in Robbins. After the end of pathology, when you sit for your second year university exam, you'll know more than what is written in the book because the cumulative knowledge of the entire year, and not just for second year, first year also, you can have a beautiful structured answer, right? That's the only thing which I wanted to tell, right? Now let's go to intracellular pigment accumulation. Let's see what we can extrapolate, and with your help, we can add a few more points which is not there in Robbins also, right? So pigment, as I said, it's a clue for diagnosis. Entire thing here for me is it's going to help me as a clue for diagnosis. That's our only goal. But yes, there are few places where it's not just a clue; it's just a pigment present. That's all. So I can have two different categories of pigments. Like some of them said tattoo. That's an exogenous pigment, right? Tattoo is not coming from inside the body; it's an exogenous pigment. And also I have few things like bile, melanin. Everything is an endogenous pigment, right? Good evening, Kamran. Okay. So both exogenous pigment and endogenous pigment. That's how we classify. That's how Robbins is also classified: exogenous and endogenous pigment. Fine. Now, apart from tattoo, which Lion said, is there any other thing which is there in the circulation which we keep on answering, which we keep on inhaling? I'm sure you know that. Every now and then there'll be a ad coming up: stop pollution, don't do this, don't do that, because it'll cause lots of pollution, right? When you inhale the air in the atmosphere, it has carbon. Perfect, right? That's definitely one of the important thing, right? Most of the pigments which is exogenous are black in color. Most of them. Oxygen is something which is not a pigment, it's a gas which is necessary for us. Along with the oxygen, we have the adulterant carbon. That's an important thing as well, right? So in exogenous pigment, I have two things here. Tattoo is important, but that's not going to have any impact health wise. But carbon definitely can have an impact health wise, right? So first is carbon dust. In carbon dust, I want you to write two different things. Answer my question honestly. Do you think in your lungs you'll have carbon particles? Yes, no. Do you think India is a carbon negative country or do we have lots of pollution in the air? We do have pollution, right? It said that If you take a breath in India for 10 minutes, that's enough, right? Priya, silicon dust will not be there normally unless you work in a place. Carbon will be there in every person in India because it's there in the pollution, right? So I have two different things. A very common finding, which is called as an anthracosis. Anthracosis is not a disease. Anthracosis is nothing but carbon seen in any urban dweller. Robin says it's seen only in urban dwellers. It's not urban. Most of the place in India is polluted, and almost every human being which is present in India, when they inhale the carbon, definitely will be there. It's just carbon deposits in the lung. This is generally asymptomatic. Like I said, it's not a pathological finding, it's abnormal, but it's not causing a disease, right? The same carbon, when it becomes pathological, I'm sure you must have read about coal minings, right? Lots of coal mines are there in a country. People who work in coal mine, will they have more carbon exposure or less carbon exposure? Obviously more, right? So that is a pathological thing. We call it an coal workers. It's seen in coal workers and pneumoconiosis. What does pneumo mean? Pneumo means something related to airway and lungs, right? Coniosis is the deposition of tiny particles in the lung, right? It's called as in coal workers pneumoconiosis. This is a pathological accumulation which will not be seen in you or me even if I live in the most polluted city in the world. It will happen only in coal workers. That's why we gave the term coal workers pneumoconiosis, right? And again, this simple thing, tattoo. Okay, tattoo. How many of you guys have tattoos here? Any one of you here? You don't? Okay. Tattoo, it's generally black in color, green in color, but these days we have very colorful tattoo. Based on the color ink what I'm putting, that color will be reflected in the dermal macrophages, right? Tattoo is an exogenous pigment again. Rahul, right, you are absolutely right. It's also present in the senna laxative, but again, you should consume good quantities of senna for that to cause pigmentation, which is very, very unlikely, right? Harsh, you are absolutely right as well. Smoking also increases pigment. Again, smoking at the end of the day, it's also a carbon particle, right? Right? It's also carbon particle. Normally, also a person will have coal dust. When a person smokes, there's more likely to have coal dust. That's all. Smoking also will increase the pigment deposition, carbon deposition here. Fine. Okay. So these are the two major exogenous pigments for us: carbon and tattoo. I'll come to endogenous. Endogenous, we'll go as per your order, not as per Robin's order. Most of you guys, when I asked about pigment, you told about melanin first, right? Most of you told about melanin. So we'll take melanin first. Though in Robbins it's written lipofuscin first, we'll go with whatever order comes for us naturally. Which means you need not memorize the order, right? Melanin. Now tell me, what is the color of melanin? Black or brown? What do you think is the color of melanin? Melanin is an brownish black pigment. It's generally a brown pigment. It's not a black pigment, it's a brown pigment, right? Generally, we think melanin is black because we always relate melanin to the hair. When melanin is very, very, very dense, it looks black in color. In general, melanin is a brown black pigment. It's generally a brown color. Okay, black, it will appear when it's more and more and more concentrated. Atif, tell me, what did your teacher confuse you? I'll answer for sure. Okay, it's generally a brown pigment, right? It's produced in your melanocytes. In the melanocytes of the skin, I can have them. Melanocytes are seen in the epidermal or the basal layer of skin. I'm sure you must have read about the layers of skin, right? What's the topmost layer called as? Just for understanding, it will be seen in the basal layer of epidermis normally. Okay, it's a very normal pigment, melanin. Fine, it's completely normal to have that. So melanin here will generally be seen inside the melanocytes, kind of macrophage kind of thing. Fine. Gohil, I will answer this question later. Is that fine? Okay. So this melanin, normally I can see them, as well as there are few conditions where I have hyperpigmentation. I'll see them when there's an hyperpigmentation as well. This is abnormal deposition of melanin when it's in hyperpigmentation, right? Now let's assume and let's learn and understand when does this hyperpigmentation happen. Perfect. So what do you think is the function of stratum basale? Let's go back to our basics. So that will help us a lot. What do you think the function of stratum basale is? Stratum basale's function is very simple. It helps in the regeneration, right? It's also called as stratum germinatum, right? Stratum germinatum is the other name for stratum basale, right? So now tell me, if I have an injury to the skin, Okay, if I have an injury to the skin, can I also say that stratum basal will proliferate more? I'll answer your question, Aditya. Just give me a second. It will proliferate more, right? Perfect. So stratum basal proliferates more. Will the pigmentation be more or less? Because stratum basal or basal layer is where I have melanocytes. It will definitely be more as well, right? So hyperpigmentation, the easiest way for you to remember is anywhere I have inflammation. Anywhere when you have inflammation, it will by default result in hyperpigmentation. Let's relate this to a real life. How many of you have heard this from your mom? Your mom must have told this for sure. Don't go out in the sun, don't play in the sun. What will happen to you? You will end up becoming black in color. The reason is UV rays causes damage to the skin. UV rays causes inflammation to the skin. And once there is an inflammation, basal layer proliferates. That causes black color or hyperpigmentation. That's how much depth Indians has science in it. Right? If you lived in India for 20 years, by default, you know good amount of science. Half of it what is given in your human physiology, right? That's much comfortable and easier. Fine. Okay, so this is a normal hyperpigmentation, right? And also I can have tumors like melanoma, where also I'll have more pigment deposit, right? That's also a condition here. Atif, to answer your question, mitochondria will be increased in quite a few metaplasias. There are some metaplasia called as an oncocytic metaplasia. We'll read them when you come to thyroid disorders because that's where it's much more explained and you'll be able to understand them. When you have an oncocytic metaplasia, there, yes, mitochondria will be increased, but not in every other metaplasia. Fine. Okay, I hope that answers your question. Priya saying whenever urine is excreted, they shouldn't change color. If it changes color, there's some abnormality there. Fine. Okay, that's about melanin. Now let's take lipofuscin. So lipofuscin is, we are going to separate it. Lipofuscin, fuscus. It came from a term called as fuscus. Fuscus means brown. It's fucus or fuscus. It's brown color, right? So it is, yes, Rahul. So it is just, I'm having a change, lipo plus fission. So it's a combination of lipid, which is brown in color. That's what we call as lipofuscin, right? We read about necrosis, right? Can I say in any tissue damage, there'll be phospholipid damage? In any cellular damage, am I right in saying that the phospholipid of the membrane will undergo damage? Yes. So can I say every damage, I'll have membrane phospholipid which will be damaged, and there is a possibility that can have a combination with the protein deposition and can give a dirt brown in color. That's what this is, right? This is what it is. So what we have is lipofuscin is nothing but it's a wear and tear pigment. There are few other names for lipofuscin. It's a wear and tear pigment. It's also a telltale sign of cell damage or telltale sign of cell injury. Okay. So what is lipofuscin primarily made of is something we read in atrophy also. Same, similar concept, that's all. So what's going to happen is I'm having a cell which is becoming older or is having a damage. So the membrane phospholipids forms a very complex combination with the protein and multiple other factors and gives a brownish color. That's all, right? So this is nothing but the composition is lipid plus protein complex and little bit more, which gives an appearance, right? Which gives a brownish appearance. So we call it a lipofuscin. It's brown lipid, to be very frank, right? It's a brown color lipid. Lipid, when it's damaged, will become brown in color. I am sure, 100% sure you know it. Have you ever seen your mom boil butter in your home, at your home? Have you seen ghee being made? I'll answer your question, Priya. Just give me a second. Have you seen ghee being made? You must have. When the ghee is being made, the lower half of the whatever vessel they use, what will be the color? The lower half of any vessel, it will become brownish in color. By default, you damage any lipid over the period of time, it gives a brownish appearance. That's what it is. Same thing what you see in real life. When it happens inside the body, I'm going to have the same color. It's a damaged lipid. Damaged lipid along with few protein complex gives a brownish color. That's it. That's all lipofuscin is. So lipofuscin is a damaged product. That's it, right? Lipofuscin, if you remember atrophy, which organelle inside my body can take this? Which organelle do you think it answers? Rahul, can you ping me later? It's a big answer, so I'll answer you separately. It's lysosome. Perfect, right? So lysosome is the one which is going to remove and store all these lipofuscin, right? So what's important for me is the location of lipofuscin. Lipofuscin is given to be an as your textbook, it's a golden brown color or an yellowish brown color because lipid is yellow in color and the brownish appearance. That's all right. It's a little bit of an yellow to brown appearance. Most of them will be written yellow to brown, but in our real purpose, it's only brown in color. That's all fine. Second, like I said, like you said, it's seen inside the lysosome. Lysosome is the one which is going to consume everything, right? So if you remember drawing any cell in your school days, where do you draw lysosome? Close to the membrane or close to the nucleus? Perfect, Kamran. You always draw a lysosome close to here, right? So this is where the lysosome is, right? It'll be in the peri or the paranuclear space. See, peri and para can be interchangeably used. It's completely fine in multiple places being interchangeably used. The location of lipofuscin is very, very important for me. It's there in the peri and the paranuclear place, right? It's there in and here, around here, fine. Most of the time it's close to the nucleus. That's the location of lipofuscin. That gives me a clue. I'm dealing with the lipofuscin. It's a wear and tear pigment. And tell me, which organ in my body tackles all the toxins what we eat? Which organ in the body tackles all the toxins what we eat? Liver? Can I say liver is something which on and off definitely will get hit? Repeated damage possible? I'm coming to it, Rahul. Possible? So can I say liver has a maximum concentration of lipofuscin, right? There are multiple organs which can have lipofuscin, but there are few important things, liver, because every day liver hits. I'm eating lots of things which are toxin. My liver metabolizes. Liver gets hit every now and then. At the same time, can I say heart is something which beats every second? More damage possible, right? Liver and heart are the organs which has little bit more concentration of having lipofuscin. Doesn't mean that my skeletal muscle should not have. It will have. My skin also has damage. It also will have, right? So these are two organs where I see lipofuscin predominantly. In a Viva, if they ask, can you see them in any other organ? Yes. Because every organ in my body will undergo damage and definitely it will undergo wear and tear and lipofuscin will definitely accumulate, right? That's about lipofuscin for us, fine. Okay, lignomelanin. Next we'll come to hemosiderin. Okay, Priya, coming back to your question, there's an endogenous pigment which can be brownish and blackish in color as well. Very rarely I have an endogenous black pigment, but I'm sure you must have heard about this. I'll give you a clue. I want you to tell the diagnosis because you already must have read this disease in your biochemistry. There's a disease where you will have black color deposition in cartilage, in the nose, in the ear lobes. It's an autosomal recessive disorder where it's an enzyme deficiency which helps to break down homogenesic acid. And this homogenesic acid is the one which gives the color. Alkaptonuria, right? Perfect. Okay, Kamran, I'll come to your question soon, right? You must have definitely heard about a disease called as an alkaptonuria, right? Yeah, this is your question. And alkaptonuria or an ochronosis, which is an autosomal recessive disorder with an enzyme defect. So here I'm having your homogenesic acid accumulation. So this homogenesic acid, okay, is going to accumulate in the cartilages, in the nose tips, in the ear lobes, in the vertebra. Multiple cartilage will accumulate, which gives a blackish color. The same homogenesic acid is the one, if it allows urine for a longer time, it will turn black in color due to the oxidation of the homogenesic acid, fine. Again, this is an abnormal thing. This will be black in appearance. This can also be added to the endogenous pigment, fine, perfect. Now let's come to hemosiderin. Okay. Kamran, in list defect, lipofuscin is a very good question, whether it be present or not. See, in list, there's a defect in the lysosome's fusion with phagocytosis, right? So, yes, to some extent, I'll definitely have a problem of eating the the autophagy also. You're absolutely right in saying that. But the only concern here is, if autophagy doesn't happen, can I say still this broken thing will be there inside the cell? My mitochondria still it will die. Lipids still it will die. It will not be in a concentrated form, it will be more diffuse. That's the only difference here. In case of lipofuscin, in a list defect. Fine. Okay. Now let's come to hemosiderin. Hemosiderin is an abnormal accumulation of iron. Have you seen rust? Have you seen rust? You must have seen rust. 100% you must have seen rust, right? What is the color of rust? Rust is brown in color, right? It's brown in color. So can I say rust is nothing but oxidized iron? Yes. The same iron particle, if it is there in the microscopy, can I say that also will be brownish in color? Ultimately, yes, right? That's where I'm having a problem. Whatever endogenous pigment we studied, be it lipofuscin, be it melanin, be it hemosiderin, what is the color? The common one is brown color. So I'm going to ask you a simple question. If I am a pathologist, I'm looking into a brown color in microscopy, can I differentiate without any other clue? It's iron or my lipofuscin or my melanin. Can I differentiate or not? I cannot differentiate. If you can't differentiate something on a light microscopy, in the last classes day we read, what do we do? Perfect. I do special stain, right? This is the only thing I want you to remember. I want an algorithm head. In your head, I just want an algorithm. I just want an approach. Facts are never useful. If you want to become an amazing doctor, develop the algorithm. Once you create the algorithm, everything you'll put into it. That's much easier. I do need a special stain. Fine. Great. Okay. Now let's come back to hemosiderin. Hemosiderin is most likely a pathological iron deposit. Let's take iron. Iron generally will be always bound with some protein. I have two types of iron protein. One is ferritin, other one is hemosiderin, right? I have both ferritin and I have hemosiderin. Fine, that's how it is. Ferritin I generally don't mind because ferritin is physiological. Do you need to diagnose the amount of ferritin in the body or not? It's not required for me, right? Ferritin is generally not required because physiological, it's normal. I don't care about it, right? I do require hemosiderin because hemosiderin is most likely pathological. Pathological iron deposit, everything will be in the form of an hemosiderin complex. Again, it's a protein bound iron complex. Physiological, I don't want to know about it. Fine. Good evening, Rajshri. Okay. Now, it's also golden brown. It's also granular or a crystalline pigment. That's how it is. Fine. So here, this hemosiderin can be deposited in a local tissue or as a systemic process also. When you fall down over a period of time, will it turn brownish in color? Is that statement right? Is it right? Yes. Right. A bruise, someone hits you. At the area of bruise, it will be brown in color. That's how it is. It's completely common to have that. It will be brown color, right? Systemic excess is also possible for me. When I say systemic excess, there are very few conditions where I can have an excess of iron throughout the body, right? One iron overload for me is your hemochromatosis or hemosiderosis, right? So we have hemochromatosis. There are two terms here. Both the terms are there in Robbins. I'll try to explain and we'll try to tell the difference between the two. And we have hemosiderosis. And these are two things. Okay. Have you heard about a disease called as thalassemia? Have you ever come across a disease called as thalassemia? You might have, right? You might have. What group of disease it is? RBC, hemolytic anemia, right? How do you think you will treat a patient with thalassemia? What is the treatment? Whatever comes to your mind, tell. You might be right, you might be wrong, doesn't matter at all. Thalassemia is an hemolytic anemia. Lysis of blood happens, so the only treatment is repeated blood transfusion, right? Perfect. So it said that for a beta thalassemia major, a very severe disease, you have to give at least one transfusion every 2 weeks or sometimes even 1 week. So more and more blood I give, is there a possibility iron overload can happen? Yes. So hemosiderosis always mentions or always talks about secondary iron overload. It's also an iron overload, but it's secondary. Like you guys said, it's secondary to blood transfusions. Okay. So secondary to blood transfusions, yes, I'll have an iron overload. I call it hemosiderosis. At the same time, you must have heard about iron metabolism in your physiology, right? You must have definitely heard about that. In your iron metabolism, have you heard about something called as an ferritin, hepcidin, ferroportin? These molecules name in iron metabolism? Yes. One of the important molecules or regulator of molecule is hepcidin, right? If hepcidin is not there, or if there's an excess transferrin, can I say iron overload will be there? Yes, that's a mutation. If it's mutation related, right? If it's a genetic cause causing an iron overload, I call it an hemochromatosis. Most likely is a mutation of DMT regulator. Most likely is a mutation of your thing. Fine. Okay, mutation of hepcidin, right? If it's a genetic mutation causing an systemic iron overload, I call it hemochromatosis. If it's an Iron overload secondary, I call it hemosiderosis, right? Osteomalacia, why techno suddenly? It's a disease of the bone which softens the bone. It's kind of equivalent to rickets in an elderly person. Rickets is generally seen in children. Osteomalacia is seen in adults. Okay, so these are two places where I can have a systemic iron overload, right? Now we saw quite a few pigments. My main goal and your main goal always is only about diagnosis. Before going to that, I'll add one more pigment which is not there in Robbins, copper. Okay. Have you seen copper wires, copper utensils, copper tumblers? These days, copper water bottles are very common, right? What is the color of copper water bottle? The color is same. What is the color? It's brown in color, right? Copper also excessively accumulates in a disease. Have you heard about Wilson's disease? If not, just remember the disease. There's a disease called as Wilson's disease, where I'm having a defect in one of the molecules, one of the transporters, which results in especially copper accumulation. You might have heard about Wilson's also. I'm not sure if they are taught that in biochemistry, in liver and in basal ganglia. How many of you have heard about Wilson's disease? Perfect. Hepatolenticular degeneration, right? Amazing. Amazing. ATP7B. Superb. I'm going to have excess copper accumulation in the liver and in the lens, the decimates membrane of the cornea, and also in your basal ganglia, right? That's about Wilson disease. This also, copper also in microscopy, will have brown in color. So my main concern is this. Whatever we have read till now, my main concern is diagnosis. I don't care what is getting deposited. We don't want the theory. Theory is just to pass the exam. Our goal is to diagnose the patient. Now, we read about melanin, we read about iron, we read about copper. All of them are brown in color. So definitely I would need some amount of stain, special stain to differentiate them, obviously, right? I need them, right? Lipofuscin I'm ignoring for a fact because lipofuscin is a very physiological pigment. It's not required for me. It will not help me for diagnosis. Melanin, the stain for melanin, I'm just going to tell you only one stain or a couple of them which is done in the lab. I have a stain called as Masson-Fontana. Masson-Fontana is a stain for melanin. This is a diagnostic implication. You can write them in your short answers in your college because it will give an extra edge. But this is the only thing I want you to remember till you practice medicine. The rest of it you will definitely remember. It's not a concern at all, right? Iron, especially hemosiderin. This stain will not stain ferritin. It will stain only the hemosiderin granules. We have a stain called as Pearl's stain or an Pearl's Prussian blue. Okay, Prussian blue is the color. It will be bluish in color after staining, right? It's a Pearl's Prussian blue stain. Okay, copper, if it's positive, it will be positive for a stain. There are two stains. I like the stain Orsine. Most of them don't like it. I don't know why. Rhodamine is a very common stain used as well. The reason why I like Orsine is it's easy to do and the outcome comes very crisply. And any practicing pathologist will love Orsine, and most of them theoretically they'll like rhodamine or rhodonine. Fine. Okay. So by applying these stains, I can easily say, okay, it's copper or iron or melanin. So it helps to easily diagnose whether it's a Wilson's disease or a hemochromatosis or a melanoma. Just for a sake, I can use them for diagnosis. Fine. Okay. That's about today's lecture. If you have any queries, do let me know. If I missed some of them, I'll definitely reply to it. Okay. Yeah, Rahul, I'll go to your query. I'm just searching for your query only. Just give me. See, Rahul, when I say it's mutated, right? When I say it's mutated, uh, there are multiple things. A mutation, is it being corrected by the repair mechanism? Then it's not a problem for me. If it's killed by apoptosis, it's not a problem for me. Only when it stays back. In addition, you, like you said, you have second hit. Yes, there is definitely a chance of melanoma happening. Fine. Okay. Atif, I would say Robbins is more than enough, right? Read Robbins. If you're able to read Robbins for general pathology, still that be with me. After that, you will have your own wings. You will fly bigger than Robbins, right? Read Robbins, take notes. Presentation is totally your skill. Maybe if you want to use any book, I'm okay with any book, but please don't leave Robbins. Okay? Dr. Priya, we will discuss about pathology. I think that will make both of us grow in life in a much bigger tangent. Okay. So all the very best. See you soon. I think the next class, I have 2 live sessions coming up tomorrow and day after in the Medit app. We will look into that session. We'll try to complete the first chapter and I'll come back to this soon. Okay. See you. Thank you. Thank you. Bye bye.